Senate Budget Subcommittee 3, our first hearing of the new year, to order. I'd like to welcome my new colleague, Senator Stone. Thank you for being here. I'll welcome myself as your new chair. Again, this is the first convening of Budget Sub 3 for this year. Today's hearing is going to focus on health issues and will cover the Emergency Medical Services Authority, the Office of Statewide Health Planning and Development, and most of the Department of Public Health's budget. Senator Stone, we're not going to have a vote-only calendar today. In fact, we're only going to vote on one item, so all the other items will be open for discussion and will be held open. The one item we'll be voting on is under Department of Public Health, item number 5, the Infant Botulism Treatment Program. Just as a heads up for you, okay? Senator Mining will, I'm sure, be joining us shortly, and we'll go ahead and invite the first panel up. 4120 Emergency Medical Services Authority. We'll go ahead and get started with the overview. I'd like to welcome you to today's hearing. And we'll go ahead and get started. I'd like to welcome Dr. Howard Backer, Director of the Emergency Medical Services Authority. Thank you for being here.
Chairwoman Mitchell and committee members Stone and staff. I'm Dr. Howard Backer, the Director of the Emergency Medical Services Authority, and this is my Chief Deputy Director, Dan Smiley. As requested, I'll provide a brief overview of the department, our budget, the status of our supplemental report, and the current budget proposals. Our EMS system in California was created in 1981 by Health and Safety Code Division 2.5 with the intent of creating a statewide system with the EMS authority responsible for the coordination and integration of all state activities concerning emergency medical services and to ensure the provision of effective and efficient emergency medical care. Emergency medical services are broadly defined as services utilized in responding to a medical emergency. So EMS is a very small department, but with a large mission, and our responsibilities fall into 3 major categories. First, pre-hospital emergency services, which are one piece of an emergency care network integrated with hospital emergency departments and other services that provide one of our major healthcare safety nets. Pre-hospital 911 services in particular are widely seen by the public as a guaranteed medical service that is provided by cities and counties. In California, there are 60,000 certified EMTs and 20,000 licensed paramedics that respond to more than 3 million calls for service. They generally take the ill or injured to one of 310 acute care emergency departments, which may be one of the designated specialty departments of trauma, stroke, cardiac, or pediatric centers. Specifically, the EMS authority is responsible for scope of practice, training standards, and regulations concerning first aid provided by public safety personnel, and for EMT and paramedic practice. We license paramedics and discipline those licenses when necessary. We also provide first aid standards, training, and regulations where appropriate for the public related to licensed child care providers and specific areas for rescuers' use of epinephrine, naloxone, which is the narcotic antagonist, cardiopulmonary resuscitation, and automated external defibrillators. Currently, we're in the process of implementing recent legislation by including naloxone in the scope of practice for EMTs and allowing its use by public safety personnel, as well as developing training and certification for the public to use the epinephrine auto-injectors. One new initiative we're involved in is an approved health workforce pilot project through the Office of Statewide Health Planning and Development to test and evaluate the use of paramedics in expanded roles of mobile health care to fill some of the gaps in local health care systems. Secondly, EMS authority develops guidelines and approves plans for emergency medical services systems that are implemented by our local EMS agencies. There are 33 local EMS agencies, 26 are individual counties, and 7 are multi-county agencies that provide day-to-day management of our 2-tiered EMS system. Direct 911 ambulance service is provided by a mixture of public and private entities, including volunteers in some rural areas. and they operate in 338 zones that cover our entire state. In this role, the EMS Authority also provides operational and quality parameters to the local EMS agencies and their provider agencies, and we develop regulations for all the specialty care systems, including trauma, poison control, pediatric emergency care, stroke centers, and cardiac centers. One current initiative is that the EMS Authority is encouraging our EMS system to conform with medical standards of documenting their patient care in electronic records that can be aggregated, analyzed, and used for system evaluation and performance improvement, and integrated into electronic medical records. We're working to exchange data with hospitals to improve both pre-hospital care and disaster care when patients may be treated in different medical systems. Our third major area of responsibility is the medical response to disaster. The Health and Safety Code states that in cooperation with the Office of Emergency Services, the authority shall respond to any medical disaster by mobilizing and coordinating emergency medical services, mutual aid resources to mitigate the health problems. So we work with local, state, and federal partners to plan for the medical impact of disasters and major events ranging from earthquakes to air crashes and from pandemics to heat waves. We are partnered with the Department of Public Health in this emergency function, and we have spent the past several years building a public health and medical response infrastructure across state and local partners. At the core of our preparedness is a staff trained in both emergency management and specific response plans. Planning is actually essential for how we will respond to specific events, how we'll interface with our local, state, and public and private partners, and how we'll work with our federal partners. Plans are necessary but not sufficient because they have to be tested and trained through exercises. For example, next week we'll have an exercise with our local, state, and federal partners to understand how we'll coordinate during a major disaster. And in a few months, we'll exercise this concept further with the Office of Emergency Services in the large statewide exercise in which we'll be joined by federal HHS and the Department of Defense. We've previously discussed EMSA's tiered response to disasters to provide emergency medical response in the field. The first tier consists of 41 ambulance strike teams dispersed in local jurisdictions that would establish a field triage, treatment, and staging site for multi-casualty events, incidences within 2 hours. These are routinely used by local jurisdictions for multi-casualty events or for hospital evacuation. The second tier consists of California medical assistance teams comprised of up to 40 members that can deploy within 12 hours and begin to treat patients in any location. These are one of the most flexible direct patient care assets because they can be deployed as a healthcare team of any size and can take on healthcare missions ranging from acute emergency care to management of evacuated long-term care patients. They come fully equipped to act as an independent team in the field. Moreover, they can work in an existing facility or in a tent that's part of their supply cache. Additional personnel can be pulled from our disaster healthcare volunteer registry that currently contains over 21,000 licensed personnel of all types, including the locally organized Medical Reserve Corps. The third tier is our mobile field hospital program, which has seen no significant change since last year. These were purchased through the 2006 state budget to provide general acute care hospital capability and to serve to replace or supplement a hospital following a large-scale disaster such as a major earthquake or severe infectious pandemic. EMS Authority no longer has funding to maintain our mobile field hospital assets. One hospital has been maintained with the ability to deploy within 3 to 7 days, but we can no longer sustain even this level of readiness into the next budget year. The other two are stored without equipment maintenance and would require several weeks to deploy. Efforts to find a public or private partner to fill this funding gap have been unsuccessful. I want to apologize for the absence of the supplemental budget report that was requested in last year's budget. I do not take deadlines lightly. EMSA has drafted responses as best we could to the questions posed. You will have this soon, and it will provide more detail on the status of our preparedness assets and resources and some additional context for the BCP. The state of our preparedness and the level of preparedness to be maintained is an issue that we've been discussing actively within the administration, and I look forward to engaging the legislature in this discussion after you've had a chance to review the report. Our current BCP is an attempt to stabilize our preparedness that's been diminished by budget and grant reductions. Your staff did an excellent job detailing the reasons for the prioritization within the BCP. Just a quick note on our overall budget. The governor's proposed budget for 2015-16 includes budget authority in the amount of $32.2 million and 71 permanent positions. Of this amount, 43% is delegated for state operations, and the remainder, 57%, is delegated to local assistance. We have two BCPs currently in the budget. One is for augmented budget authority for special fund, which is our EMS personnel fund. This is fees generated by paramedic licensing. And what we are trying to do is move from a paper-based system to an electronic system, and this augmentation would allow us to scan in old records, which now have to be searched out to support new requests and then refiled. So it would make it much more efficient for us when we have all the records electronic. So some of the initial expense would be to the major push to get all the records electronic in our system. We already have an electronic registry of all the EMTs. And then we would use the resources, the ongoing resource of the office technician to maintain or to improve our and reduce our backload and improve our efficiency of licensing, new licensing, and for relicensing applications. The other BCP is a general fund request for augmentation of $500,000 in two positions to stabilize disaster medical preparedness resources to competently respond to a moderate incident and initiate a response to a catastrophic incident. The additional funding and new positions requested would be utilized to reestablish a Southern California component of the California Medical Assistance Teams, the so-called CalMATs, and support existing disaster medical preparedness programs, including the Ambulance Strike Team program, the overall CalMAT program, and a training and exercise program. We would also use the positions in the true spirit of integration with public health to coordinate the joint activities with the Department of Public Health's Emergency Preparedness Office, including activities related to catastrophic event planning, which is driven by the Office of Emergency Services and FEMA, and to coordinate our Emergency Operations Center, which we share with the Department of Public Health. So I think I'll stop there and thank you for your attention and see if there's any questions I could answer today.
Thank you very much. Any questions? Senator Stone.
Thank you, Dr. Backer, for your presentation. I really appreciate it. As you may or may not know, I'm kind of new to Sacramento, so you'll forgive me if some of my questions seem a little parochial. But you know, I come from the private sector as a healthcare professional, and over the past 10 years, I was on a board of supervisors and worked very closely with our emergency response apparatus. And in Riverside County, we certainly have had a number of emergencies where we've had to mobilize for fires, and of course, earthquakes are always a concern. Can you just briefly tell me the relationship between OEMS and FEMA and local EMS programs in all the 58 counties in the state?
The emergency management system is based on a system of mutual aid. So the local jurisdictions have the primary responsibility, as for many other programs, for any incident. So they initiate the response and have the overall control within their local jurisdiction. When their resources are exhausted, they first turn to the region, and we have what we call regional disaster medical and health specialists and coordinators that work in coordination with both us and the Department of Public Health. And they work very closely with the medical and health operational area coordinators, which is usually public health officer or the EMS director in the local jurisdiction to try and mobilize resources within the region. If that is unsuccessful, they turn to the state for their resources. And they would come to us, and we would be working closely with the state governor's office of emergency services to secure those resources. Now, you know, in most local small incidences, the locals never turn to us. We stand at the ready. For a moderate incident, and so let me just give you some examples of those. Might be fires in your local jurisdiction that don't get, you know, excluding fires like the massive San Diego fire several years ago. Multi-casualty incidences like recent, we've had a couple of large bus crashes, train wrecks, things like that can usually be handled at the local level. Maybe they'll call in ambulance resources from other jurisdictions. But for larger instances, they'll go regionally, like the Napa earthquake was handled regionally, and the state really didn't have to provide resources, but they did. Our regional coordinator helped to bring in resources from neighboring jurisdictions. When we're talking about catastrophic events, like the anticipated large earthquakes on the northern or southern end of the San Andreas Fault, then we know that the state will have huge responsibilities, and not only the state, but we will be relying heavily on federal assets. And we are planning, we do this catastrophic planning with our federal partners to be ready for that. And there is a very, been a large change in the last 10 years in FEMA and in Health and Human Services, where they are leaning forward. And in these plans, we determine what resources might be necessary for these worst case scenarios, and those would be immediately mobilized and pushed into, you know, towards the affected area, and then we would be working with the locals to determine actually where these are needed. So in fact, these exercises coming up in the next few months are just for that. We have a massive list of resources that would be brought in for a major Southern California earthquake. We know that the state does not have a lot of resources. I mean, we have some. Our medical teams, if our hospitals are still intact, those would go out to the field. But we'd be bringing in huge resources from federal HHS and from the Department of Defense into the areas to try to meet the medical and health needs.
Okay, so it sounds like based on the severity of the incident, that would kind of dictate who the lead agency is in managing an event.
No, well, no, the lead agency is always, at the local level is the locals, at the state level is the Office of Emergency Services. Okay. And we're the lead for coordinating the medical and health side, but that has to be integrated with many other emergency functions within the state. Right. And the feds cannot come in without our invitation and resource request. But we've got it all queued up, is what I mean, so to minimize the delays, because there are inherent delays in bringing federal resources from around the country.
But in order to get the federal resources, we have to have the governor declare a state emergency first, correct?
That would be one of the steps, and that would be very rapid.
Okay. And then it's your agency that certifies paramedics in the state of California, correct?
That's correct.
Okay.
We license them.
You license them. Do you know, is needle tracheostomy now a part of the curriculum for paramedics? Are they allowed to do that in the state of California?
It is a part of the curriculum.
Okay.
Yeah, okay. It's in the basic scope of practice, which means across the state they're able to do that.
So counties have the option of doing needle trachs, which I think is really important. In my district, we had a child that inhaled a little small ball, and at that time needle trachs weren't being allowed, and then unfortunately the patient succumbed prior to getting to the hospital. You talked about naloxone auto-injectors. Can you just expand on that a little bit, obviously for opiate overdose?
Yes, in the last few years, there's been, the recognition that narcotic overdoses, there's been a huge increase in narcotic overdoses, and it's not so much the illicit heroin overdoses, it's actually the iatrogenic, it's medical prescribed medication, which has gotten out of control. And our paramedics and actually our EMTs have had the optional scope of carrying that and it's a remarkable medication that it almost immediately resuscitates someone from deep narcotic overdose. The current thinking is that the more we can push that out into the communities, that the more people could be saved from narcotic overdoses. So there's been initiatives around the country to make sure that law enforcement have access to it, since they're often first on the scene for these, and also to make it available to the public, because it is a very safe medication. The complex part is if the person has other issues going on. It may not be a narcotic overdose, may be a mixed overdose. So anybody providing first aid or resuscitation needs to know how to do more than just administer naloxone. And actually the best way to do it for the public is there's a nasal spray, which is much cheaper than the auto-injector.
Madam Chair, as you know, for anaphylactic shock, we have emergency epinephrine injectables. And if you have a patient that's unconscious and you suspect that it's a narcotic overdose, like Vicodin is a narcotic, you can stab somebody with one of these devices. And if it's not narcotic, the drug is not going to hurt them. It's going to resuscitate them if they have an opiate overdose, which I strongly support paramedics having that possibility.
The public is getting an expanded scope of practice recently.
Yes. And just so you know, that naloxone is what's called a narcotic antagonist. Just reverses the effects of narcotics that are in the bloodstream. 2 more questions and I'll move on. Mobile hospitals. I know we have one functioning right now. I know it's probably a budget issue. You've got a couple of them being mothballed in storage. Have you explored public-public partnerships with counties? I think if they knew the infrastructure was there, they'd probably help store them in the event of a catastrophic event. Certainly in Southern California, we'd love to make those available to us.
Yes, sir. I personally spent several years trying to identify
because we asked that of you, as I recall, when Senator Monty and I were in the Assembly side.
And private partnerships, and I've gone to everyone. Now, we did ask the locals, but we did get the locals to take a lot of other kinds of assets that the Department of Public Health had stored, including what we call alternate care site caches, which are cots and supplies that can be set up in any existing facility, and some other things like antivirals, or well, not the antivirals, but the masks, respirators. But the mobile field hospitals take a considerable amount of storage. They're very large assets. And we were not able to get our local jurisdictions, but not only that, we went to our federal partners. We've been to NGOs, looking for someone we could partner with, in exchange for them having access to use it, that we could share the cost of storing, and we have not been successful in that.
I also applaud you going paperless and going electronic, which I think is going to make you run more efficiently. And I know that you've got about $2 million set aside in an account. Do you think you're going to need that whole $2 million for that conversion, or is it possible to utilize some of that $2 million for the 3 positions that you're seeking funding for?
I think I'll turn to Dan or Sean for that.
The actual fund balance, or the fund reserve that we currently have, will be utilized for those document imaging costs. So there will be no increased fees to EMTs or paramedics as a result of that.
But do you think that the cost is going to be close to $2 million, or do you think there'll be some savings that could be used for some of these salaries?
Well, I think that what'll happen is we'll be able to redirect some of our internal staff to deal with some backlog on some other issues that we have within the department. Additionally, we're going through the process of going electronic as well too, and move to an online licensing system, which is going to take up some of those costs as well too. So working within the existing budgetary balance, we'll be able to achieve multiple pieces to the whole licensing program.
One final question and comment. Thank you, Madam Chair. I was a strong proponent in Riverside County in exploring a pilot program. As you know, Los Angeles County has some freeways that are a little bit congested. Riverside County's got some freeways that are congested. We have, horrific accidents, and sometimes it takes emergency services a long path to get there because of the traffic, and unfortunately the patient expires by the time we get there in sanguination, bleeding to death. Dade County had a pilot program with motorcycle paramedics that has been enormously successful. And I just came back from APAC, and in Israel, they have paramedics that are on motorcycles. I got a picture of one, which I'd love to forward to you.
I've actually seen that, their program. Yes.
So I wanted to just instill with my colleagues here today that I think that California, which I think should be a leader in everything that we do, should emphasize the importance of paramedics on motorcycles. Maybe we have a grant program that provides those motorcycles for local government to use, because we can get to the site much quicker on a motorcycle and get those emergency responders there that I know will save lives in the state of California, and it would be a very small investment to make.
That's a very interesting concept to get a first responder there. Of course, they couldn't transport the patient until they got an ambulance there, but we currently do that in communities with the fire agencies doing first response, often with a fire truck, you know, just to see and stabilize the patient if necessary, and then an ambulance arrives to transport.
Thank you, Madam Chair.
Senator, do you know how it's funded in Dade County?
And Dade County is a part of their regular budget.
Okay.
They buy the motorcycles, they fund them through their
Just as you buy an
employees.
ambulance or, interesting. Senator Monty. Thank you, Senator Stone.
Thank you, Madam Chair. And yeah, just to second, that sounds like a great strategy to explore. The first responders in most of our communities are fire departments, and they're often large, cumbersome fire trucks that if they hit traffic or other impediments, they can't get there. I just wanted to follow up very briefly. I know we've talked about this in the past, about the mobile field hospitals, and it's set forth understandably prioritizing the other medical assets with the budget. But I am concerned we've gone from 3 in the past to now 1, and our notes say that 1 will be considered non-deployable after July 1st of this year. So that means we'll have no capacity. How, in your view, how does that, to what extent does that compromise the state's ability to respond to a major catastrophic event, say an earthquake in an urban area?
The hospitals were purchased with the concept of being used in a catastrophic event, and that could be either one of the earthquakes in our major population areas of California, or a serious pandemic, not like H1N1, but what we had been planning for when H1N1 came along, which is like the bird flu, or it was a much more virulent pandemic, which would overwhelm our current hospital situation. So without the mobile field hospitals, we would be relying on federal assets, and you know, we would set up in other existing facilities with our medical teams, and then rely on federal assets. There is an inherent delay in bringing in large federal assets. So,
do you know how much longer this says now down to our 1? It's 72 to 96 hours to deploy. How much longer would it be if we're relying on federal government?
Well, originally with a contractor, we had a guarantee of being in operation within 48 to 72 hours for our own hospitals. You know, the federal government doesn't have these. The Department of Defense has these kinds of hospitals. The federal government does not. They have medical teams that would set up in an existing facility. So we could get medical care in, but where we would care for large numbers of casualties, you have to have all the equipment, as well as, you know, equipment, personnel, and beds of some kind. So we'd be improvising at local, with local facilities, but the estimate for bringing in most of the federal resources is approximately a week.
Well, again, I guess, you know, the concern, and it does sound like you're prioritizing resources that deploy medical teams, which gets care to people, but to go from 3 to 0, and I know you've made efforts to find private partners, nonprofit partners. Red Cross on that list of people you've
Absolutely, yeah, I have very close connections with Red Cross.
I remember.
Yeah.
I mean, there's no question. We were very happy when we obtained the asset, and we you know, it can be a very valuable asset in the right situation. You know, there's no question about that.
Can you remind me if we've ever utilized the asset?
No, we have not utilized we've used them in exercises, but we have not had a catastrophic event since they were purchased.
And they were purchased when?
2007.
Yeah.
Right before our economy.
But then it must have been 11 or so, because we heard this every year in sub 1 that they began to kind of scale down. So
Right.
we've had them and not used them, and we've only had them for a relatively short period of time.
Well, appreciate the framing and the prioritization, and would just encourage, not to denigrate your efforts to try to find partners, it just, if these assets are sitting there collecting dust and we're paying rent, I don't know, maybe someone would be interested on Craigslist.
Or one of the movie studios for one of the films.
Right. Yeah, use it.
Catastrophic.
Yeah, Hollywood. Maybe they've got a warehouse where they could have, it would be a partnership. They could use it for a film shoot, but
Right.
it's.
Give it back
but
to us
Give
when
us
needed.
back to us if we need it.
Mr.
Thank you.
Mr. Stone.
I believe FEMA does have some of these mobile hospitals that they can deploy pretty fast in a national emergency. And it's not a matter of if, it's a matter of when these units are going to be deployed. And certainly mothballing them because we haven't had an event increases the odds that we're going to have an event sometime in the future.
Right.
And in Riverside County, we do have at least 2 mobile hospitals that was bought by private donations and has been mobilized to some of our events. And fortunately, it hasn't been needed too much, but it's nice to have the security blanket to know that they're there. I would encourage you to reach out to counties and like Riverside County, the 4th largest county, San Diego County. I would imagine that they would be interested in a public partnership, because I think that the challenge for the state is deploying the vehicles and the infrastructure to the site of the disaster. It's easy to get the personnel there, but it's hard to get the equipment there. Maybe strategically placing them in the state of California within counties and asking them, can we store the vehicle? Will you maintain the vehicle? And when we need it, we have it at our disposal. I'm sure that they would probably embrace that as a way to augment
Originally,
their
that
own.
was the design. We had these strategically located, one in the Bay Area, one in Southern California, and one in the Sacramento area.
So I hope you'll further those discussions, because I think you'll find some CEOs of counties may say that that's something they can certainly embrace.
I think the challenge, Mr. Stone, because Senator Monty and I tried everything short of storing them in Senator Monty's garage. I mean, it was just we really struggled with this, and we really pushed hard on the administration. I think the challenge is the counties don't have the resources either in terms of storage, all the things the state is facing in terms of storage and having to invest. It's not as if it's a one-time investment, and those are sunk costs forever. You know, the materials, as you well know, have to be maintained and kept up, and so we will ask you again, but I think the counties also said, yeah, thanks, but no thanks unless you're going to pay for it state. We circled the wagons repeatedly on this issue. It was a tough decision. We pushed hard.
It does require some ongoing investment for maintenance, and it's relatively small compared to the initial purchase cost, but it is an ongoing cost.
But remember, a lot of these counties have fleet services that can maintain these and store them on their storage. I mean, we have 5,000
I think this is a little bit bigger than what the hospitals or what you're talking about in your county, because we're not aware of any of the counties having anything like this, except Los Angeles County has a 100-bed unit, but these are quite large.
Okay, so we're talking about something much smaller. Absolutely.
Thank you. Finance. No comment. LAO. Nothing. Excellent. We'll open it up for public comment. Seeing none, thank you very much for your presentation.
So much.
One quick question. We're going to hold the issue open. Okay. Do you have a general idea when your supplemental report will be prepared and ready for that? I'm sorry, I didn't mean to put you on the spot. You can talk in season. Springtime, winter, give us a general sense.
I am driving this almost by the day. I'm making myself a nuisance, but I'm going to try to, I wanted to get this to you before our testimony, obviously, here, and I will keep pushing, because it has to get to you so that we can
close this item out.
Yes.
Exactly. Okay, so we'll hold this item open. Thank you very much.
So it will be this season.
Okay, thank you. This season. All right.
Thank you so much.